Jim's going to come back up. Frank Arco, I think, is sick.
Sick, yeah.
He's
So
got a
this is
fever.
a standard presentation, so
Right.
we won't have AV issues.
So Jim's a McKinsey, or he's step in here to fill
Yep.
this.
All right. So this is one of the new FDA-approved devices. It's been mentioned several times throughout the course of this meeting. And, you know, obviously we're trying to preserve the subclavian artery. Originally we had some concept, could we just cover the subclavian and what sequelae would be? Well, obviously we worry about spinal cord ischemia, stroke. If you've got somebody that has a left internal mammary bypass, you obviously got to keep the left subclavian going, and you also run the risk of arm ischemia. So we're now looking at the TBE, and basically, if you look at it, there's good evidence that we need to try and preserve the subclavian artery in most cases. And I think the current SVS guidelines are, in elective cases, you should preserve the subclavian artery either by carotid subclavian bypass, laser fin, or some form of reperfusion of the subclavian. And this is well supported. The actual thoracic branch endograft trial was performed. It was through a series of screening of over 500 patients. They had 85 patients that underwent TBE. The results were actually very good. The main issue was periprocedural stroke in 3 patients out of the 85 that were treated. The all-cause mortality was 4, and none of those were related to the aneurysms that were treated. And one patient had an aortic arch reintervention. And so here shows the patients coming in with a type 3 arch coming in, and they're able to land the TBE and keep the portal going up for the left subclavian, maintain perfusion, and seal the aneurysm. And you can build down with that for thoracoabdominal aneurysms also. 2 quick cases here. This is an 86-year-old woman that has 7-centimeter proximal descending thoracic aneurysm, usual comorbidities, and it had expanded about 5 millimeters in a series of 4 months. And you can see the 3D reconstruction here showing that very proximal subclavian aneurysm. We came in and saw obviously had a bovine arch and concern for the left subclavian perfusion. We were able to come in with the graft. The biggest concern or problem I had with it is you've got to watch out for wire wrap because you've got a preloaded wire coming up through the subclavian. You snare it, but you got to make sure that it lines up nicely. And if you don't have it in position, you need to bring the whole TBE graft down to the descending thoracic aorta, try and unwrap it, then advance it again. And that was the main issue we had here, but we were able to bring it back up. Very precise deployment. Obviously, when you're dealing with a bovine arch, you want to land right up to it, but not impinge on it. We were able to come in and then put the thoracic aortic endograft in place, as well as the branch going to the left subclavian, all done just from a left brachial access, or you can do radial and a femoral access. And then her follow-up showed complete exclusion of the area of her aneurysm, and then she's done quite well. This is a second case that tends to be it's not, Gore is not supporting this. It is a zone 0 TBE. A 50-year-old male that presented had a type A dissection that had a stroke around the time of his type A dissection, had a Bental down in North Carolina, and then had a second stroke about a year after that. I am still recovering from that second stroke. He had a descending dissection that had gone through the arch, up the innominate, up the left carotid, and then down in the descending thoracic aorta. He came back with aneurysmal expansion and chest pain. Here's a CT scan. You can see the innominate dissection, the large aortic dissection, and a rather subtle descending thoracic aortic aneurysm. It had renal stents put with a petticoat due to severe hypertension, which actually helped in resolution of the hypertension, but he still had pain. We referred him to our cardiothoracic surgery colleague saying he needed an arch replacement or frozen elephant trunk. They refused because of his stroke. And we referred to a second cardiothoracic group, and they too refused, and he came in again with progressive pain. So we then went ahead and performed a carotid subclavian bypass, as shown here. We had to do an interposition graft for the left common carotid because he had dissected all the way up, so we replaced the left common carotid. And we also had issues because the dissection had gone out into the innominate, and so we had to go beyond that area into the common carotid to land our TBE. So here you can come in, you can see we actually built up into the common carotid. I did a carotid subclavian on the right at this time, actually opened the subclavian and found that we were in the false lumen, and so I had to do a septotomy in the the right subclavian to make sure we're perfusing the true lumen, and use the proximal aspect of the carotid subclavian to deliver our branch grafts as it comes in and control that. Here you can see the TBE coming down. And this gave us excellent perfusion to the visceral vessels, the carotid subclavian, and then left us for putting a tag graft distally once we had got the patient stabilized from this procedure. So we did that as a staged procedure. But overall, this is what worked exceptionally well, totally excluded his arch aneurysm, and gave us a great platform for building down for his descending thoracic aorta. So that's using the TBE. I think it's a great augment. The biggest issue is you got to make sure you have the wires not wrapped as they go up, and then make sure you bring it down the descending thoracic to unwrap it and push it back up. So
Good. Thanks.
thank you very much.